Hi everyone, Andreas, Madeline, and I will present on sexually transmitted infections. To start with basic information about STI, the term STI is a broad term that refers to any infection transmitted through sexual contact by bacteria, virus, or parasite. It does not specify a particular diagnosis. Transmission can occur through fluid exchange during vaginal, anal, or oral sex, or by sharing sex toys. Certain STIs like herpes simplex virus and human papillomavirus can also spread through skin-to-skin contact. The risk of transmission through surface contact is low as these microbes need warm and moist physiological conditions to survive and multiply. Regular screening is essential for everyone who is sexually active, as many STIs can be asymptomatic and therefore difficult to identify without testing. The CDC recommends testing every 3 to 6 months for those who have multiple or anonymous partners. If left untreated, chlamydia and gonorrhea can lead to pelvic inflammatory disease and scar tissue development on the fallopian tubes, which can increase the risk of ectopic pregnancies in the future. Oral and rectal infections are often asymptomatic and may act as a reservoir for sustained infection and contribute to antimicrobial resistance, so prompt treatment is important. Certain STIs such as HIV, syphilis, herpes, and chlamydia and gonorrhea can also be transmitted from a pregnant person to their child during pregnancy, delivery, or breastfeeding if left untreated. While bacteria STIs like chlamydia and gonorrhea can be treated with eye drops in newborns, a scheduled C-section may also be necessary to prevent transmission during vaginal birth. Antibiotics can effectively treat bacterial and parasitic STIs, but viral STIs cannot be cured easily. However, medications can alleviate symptoms and reduce the risk of transmission to future sexual partners, allowing individuals with lifelong diagnosis to have fulfilling and active sex lives.
All right, so I'm going to talk about neurosyphilis. So before that, we need to talk about syphilis. What is syphilis? Syphilis is an STI that is caused by the Treponema pallidum bacteria. Syphilis is contracted via direct contact with a syphilis sore during vaginal, anal, or oral sex, a characteristic Yane mentioned earlier that is similar to other STIs. Even after antibiotic treatment, syphilis can be contracted again if the individual comes in contact with another syphilis sore. Syphilis can even spread from a mother to her unborn baby during pregnancy. Now I'm going to go over the stages of syphilis. In the first stage, painless sores emerge on the penis, vagina, anus, rectum, or lips or mouth after 3 to 6 weeks of exposure. Next, in the second stage, which occurs 4 to 8 weeks after exposure, itchless skin rashes emerge on one or more areas of the body, accompanied by fever, sore throat, hair loss, weight loss, fatigue, and muscle aches. After the secondary stage, most individuals with syphilis enter the latent stage, which is a stage where there's no visible symptoms. But sometimes individuals can enter the tertiary stage. The tertiary stage of syphilis is serious and occurs 3 to 30 years after infection. It involves damage to internal organs and can result in death. So what is neurosyphilis? Neurosyphilis is an infection of the syphilis bacteria, Treponema pallidum, that causes harm to the meninges of the brain, and the spinal cord. NS occurs in 25 to 40% of individuals with syphilis if left untreated. There are 5 types of NS. Asymptomatic neurosyphilis is when neurosyphilis is present, but the individual does not have symptoms and does not feel sick. Meningeal syphilis can occur between the first few weeks to the first few years of getting syphilis. Individuals with meningeal syphilis can have headache, stiff neck, nausea, and vomiting. Sometimes there can also be a loss of vision or hearing. Meningeovascular syphilis causes the same symptoms as meningeal syphilis, but affected individuals also can have strokes. This form of neurosyphilis can occur within the first few months to several years after infection. General paresis can occur between 3 to 30 years after getting syphilis. People with general paresis can have personality or mood changes. Lastly, tabes dorsalis is characterized by pains in the limbs or abdomen, failure of muscle coordination, and bladder disturbances. Other signs include vision loss, loss of reflexes, and loss of sense of vibration, poor gait, and impaired balance. Tabes dorsalis can occur anywhere from 5 to 50 years after initial syphilis infection. And another thing to note is general paresis and tabes dorsalis are the two less common forms of NS, and that's due to advances in screening. People with HIV and AIDS are at a high risk for NS due to a weakened immune system. The best form of treatment is penicillin for syphilis. And for neurosyphilis, it's an antibiotic called ceftriaxone. Treatment outcomes and prognosis depend on the individual and when the infection is diagnosed. Individuals with meningiovascular syphilis, general paresis, or tabes dorsalis improve, but sometimes do not return to normal health. I'm now going to go over a study that was conducted on neurosyphilis called the Psychiatric Manifestations as Primary Symptom of Neurosyphilis. This study was led by Dr. Tian Chi Yang and Li Liu at the Research Institute of Xiamen University. So, reported by the National Sexually Transmitted Disease Surveillance System in China, there was a 419,306 or 16.95% increase in syphilis cases between 2010 and 2011. As mentioned previously, if left untreated, syphilis develops into NS in 25 to 40% of cases. NS is difficult to diagnose because it presents similarly to personality disorders, psychosis, dementia, cognitive impairment, dysphoria, or elevated mood, hallucinations, mania, and delirium. So definitely more studies are needed to better understand a neurosyphilis. In this particular study, though, 126 male and 43 female syphilis-positive patients participated. These individuals tested negative for HIV infection, were not returned visiting, and had no family history of psychiatric disorders. The researchers conducted cerebrospinal fluid protein analysis and MRI assessments. For the results, 59 of the 169 were diagnosed with paresis. Of the 59, 52 had psychiatric manifestations. 11 of the 52 with psychiatric manifestations had already been diagnosed with neurosyphilis at a previous hospital. The 41 that remained were first treated in the neurology department at a hospital without ever having been suspected of neurosyphilis. The most common original diagnosis of the psychiatric manifestations was dementia. And that was the original diagnosis. So when these patients first arrived at the neurology department, they were diagnosed with dementia. But in the study, upon examining the 52 individuals who presented a psychiatric manifestation, the most common was cognitive impairment, followed by personality disorders and then delirium. The most common clinical manifestations were amnesia and muscle weakness. While 30 of the 52 patients presenting psychiatric manifestations underwent MRI assessment, 21 of the 52 patients had abnormal MRI findings. Cerebral atrophy and infarct ischemic stroke were the most common brain abnormalities, which are both pretty serious. The biggest takeaway from this paper is the idea that even medical professionals, like clinicians, psychiatrists, and neurologists, were not aware of the possibility of neurosyphilis being the cause of psychiatric manifestations for 41 patients in the study. These medical professionals misdiagnosed a significant portion of neurosyphilis patients due to a lack of awareness and education. Similarly, 17 of the neurosyphilis ischemic stroke patients were also misdiagnosed upon arrival to the ER, a serious life-threatening event. It's clear that neurosyphilis can be life-threatening, so rapid and early diagnosis is essential to preventing disease progression and potentially irreversible brain damage. Neurosyphilis should always be considered as a differential diagnosis in patients who present with unclear mental abnormalities. Lastly, the researchers of this paper recommend that all patients with clinically evident neurological or psychiatric symptoms should get tested for syphilis. My discussion question is providing education, how the infection works, and potential symptoms about neurosyphilis enough to reduce its infection rate, or does the stigma around syphilis need to be considered in the approach as well? Thanks.
So in the context of STIs, I will be talking about HIV/AIDS. So HIV, also known as human immunodeficiency virus, is a retrovirus that attacks cells that essentially help the body to fight infection, specifically CD4 T lymphocytes, which by attacking these lymphocytes makes a person more vulnerable to other infections and diseases. And CD4 T lymphocytes are a white blood cell, and they are also known as a helper cell that help the body fight infection. So HIV is spread by contact with certain bodily fluids of a person with HIV, including blood, semen, vaginal fluid, anal mucus, breast milk, and it's most commonly spread during unprotected sex or through sharing injection drug equipment. And there is a much higher risk of transmission of HIV through anal sex, specifically receptive anal sex, followed by vaginal and oral sex. So HIV is detected through a blood test, but it can take from 6 weeks to about 6 months for an infected individual to test positive, even if they're infected already and capable of infecting others. So they also may not display any symptoms until the 6-week to 6-month period either. And if this is left untreated, the HIV can progress to the advanced stage, which is known as AIDS, also known as acquired immunodeficiency syndrome. So AIDS occurs when the body's immune system is badly damaged because of the virus. More specifically, a person is considered to have AIDS when the number of their CD4 cells falls below 200 cells per cubic millimeter of blood, compared to a normal number of 500 to around 1600 cells. They can also be classified as having AIDS if they develop one or more opportunistic infections. This is most often seen as the development of cancer, regardless of their CD4 count. So unfortunately, the human body cannot get rid of HIV, and currently there is no effective cure, but it can be controlled. And also, if you have HIV, you have it for life. So as Yane mentioned earlier, as with some other STIs, there is an effective HIV medicine that's available. And if it's taken as prescribed, it can reduce the viral load of HIV or the amount that's in the blood. Individuals who maintain a low or undetectable viral load can live long and healthy lives and will not transmit HIV to their HIV negative partners through sex. Fortunately, there are also pre and post exposure prophylaxis options available for HIV. If you don't know what prophylaxis is, it's essentially a treatment or actions that are taken to prevent a disease. So the pre-exposure prophylaxis, otherwise known as PrEP, is a preventative medication that's taken daily, which means it prevents HIV if an individual takes it before they're exposed, And this is especially useful if an individual believes they may be at high risk of HIV. PrEP can also reduce transmission from sex by about 99% and from injection by about 74%. PEP, on the other hand, is post-exposure prophylaxis, which is a treatment plan for after a person is exposed to HIV. This is taken as a daily medication for 28 days, must be started within 72 hours of possible exposure, reduces risk of HIV transmission by about 80%. And both PrEP and PEP have minor side effects such as nausea, diarrhea, headache, and vomiting. So I will be discussing our next paper, which is titled HIV-associated neurocognitive disorder, pathogenesis, and prospects for treatment. So the main researcher of this paper is Dr. Justin McArthur, who is the director of the Johns Hopkins Department of Neurology and neurologist in chief at the Johns Hopkins Hospital. So Dr. McArthur's research and his clinical focus is neuroimmunology, specifically on HIV and the epidemiology and treatment of neurological manifestations of AIDS. The purpose of his review paper is to describe the neuropathogenesis and epidemiology of HIV-associated neurocognitive disorder and how inflammation is sustained in chronic HIV infection, as well as new approaches to treatment and current research through animal models. So HIV has been shown to have detrimental effects on the brain. It's able to infect the central nervous system early in the course of infection, where it establishes a reservoir in the brain, which in return creates a pro-inflammatory and neurotoxic environment, and this results in neurodegeneration. And it essentially does this by migrating across the blood-brain barrier via infected monocytes and blood lymphocytes. This then results in neurological damage, which is termed as HAND, or HIV-associated neurocognitive disorder. And I'll be using this acronym quite a lot throughout my discussion of this paper. So HAND includes 3 levels, the most severe of which is HAD, or HIV-associated dementia. The second most severe being mild neurocognitive disorder, or MND, and the mildest, which is asymptomatic neurocognitive impairment. Symptoms of HAND include deficits in attention, concentration, memory, low motivation, irritability, depression, and motor dysfunction. So with advancements in neuroAIDS research, there's been a development of a combined antiretroviral therapy. This is known as CART, which is able to reduce the occurrence of HIV encephalitis or inflammation observed at autopsy to reduce from 54% pre-CART to 18% in the CART era. However, it has not decreased the prevalence of HAND. And although CART has decreased the severity of HAND, as shown by a decreased percentage of HAD, as you can see, dementia has decreased in size in this chart, and mild and asymptomatic have increased. It does not affect the prevalence of HAND overall. As you can see, 53, 54%, no change there, which indicates that the viral load is not the crucial driver for HAND. And in the paper, it suggests that functional alterations in neurons may be the cause of this continued prevalence. So despite the ability of CART to reduce the occurrence of HIV encephalitis, central nervous system inflammation plays an important role in triggering the events that lead to neurodegeneration in HIV infection, and the inflammation is sustained even when viral replication is suppressed by CART. Furthermore, in individuals treated with CART, risk of hand increases with age and in the presence of certain risk factors such as cardiovascular disease. The brain has also been identified as a reservoir for persistent HIV infection, and the latent form of HIV can persist in the brain despite CART treatment, since CART is unable to cross the blood-brain barrier. So the existence of viral load reservoirs, along with the inability for it to cross the blood-brain barrier, results in persistent HIV infection. Therefore, CART suppresses HIV replication, but ultimately it fails to cure HIV infection due to the existence of HIV latent reservoir. So HIV positive patients exhibit widespread alterations in the expression of genes that regulate brain energy metabolism, and dysregulation progresses over time. This results in deficits in motor and psychomotor speed, attention, and memory. And this ultimately suggests that loss of bioenergetic homeostasis in early stages of HIV could be an event that primes the central nervous system for functional deficits. Therefore, it's very critical to consider the central nervous system when considering the potential eradication strategies moving forward. So my discussion question is, despite our increased understanding of the pathogenic mechanisms underlying hand, why do no clear adjunctive treatments exist? And what potential treatment approaches might you suggest? So now I'll hand it back off to Yane.
Now I will talk about the social and cultural implications of HIV. There are many stigmas surrounding HIV and AIDS that have persisted for decades, such as stigma against people living with HIV, LGBTQ plus individuals, people who use drugs, and sex workers. These stigma are detrimental in a variety of ways by preventing one to receive treatment, perpetuating discrimination, and causing mental health challenges. Emily Arnold is the main author of the paper Triple Cursed. She is currently an associate professor at UCSF Medical School. Her research focuses on the intersections of culture and health behaviors, since they're associated with gender, sexuality, and HIV-related risk behavior. A lot of her work has been related to sexual culture among gay and bisexual men and its influence on sexual identity, sexual behavior, and HIV risk practices. She also researches about the development and testing of HIV prevention interventions for African American men who have sex with men, including those who do not necessarily identify as gay. In fact, she has developed the Bruthus Project with CalPAP. This project is a 4-session counseling intervention for African American men who have sex with men and women, and Dr. Arnold wishes to present that this project can lead to less HIV-related sexual risk behavior and more regular HIV testing. Being involved in the visiting professors program at CAPS, she also contributes to the program's objective of reducing health inequalities by expanding the pool of scholars from underrepresented communities who can engage in thorough research. This goal aligns with her previous studies, which have demonstrated her dedication to this cause. As Madeline talked in depth about HIV, the previous focus of reducing HIV incidence is on testing, linkage to care, and treatment, which makes HIV a very personal issue. Thus, stigma and social barriers play a big role and are important to understand the social meanings about HIV diagnosis and homosexuality, especially among gay men of color, as they are disproportionately impacted by HIV and AIDS in the US. The study by Dr. Arno conducted anonymous interviews of 31 Black self-identified gay bisexual men aged 18 to 30 years. 74% identified as gay, 16% identified as bisexual, and 48% report to be HIV positive. They were asked questions related to family, sexual identity, history of HIV testing, HIV disclosure, thoughts on HIV prevention for young Black gay men. After analyzing the interviews with a thematic analysis approach, they found 3 important themes. The first one is homophobia and HIV-related stigma present within the larger social context of racism. In fact, over 50% of the participants reported that they were rejected from their immediate family members when they came out as gay or HIV positive. This led to the second theme, in which the paper found that coping strategies of unprotected intercourse with other Black gay men were frequently related to the social rejection stemming from racism and homophobia. The participants described their engagement in intercourse without a condom to feel the love they need, as family and community-based support were withheld. They mentioned that it helps them feel validated and be accepted. Last theme turned out to be how anticipated slights, and rejection hindered efforts to disclose a positive serostatus. Participants explained how the air of gossip and judgment in the Black gay community led young people to be hesitant to share their status or to seek support or to even get tested, as they don't want to be seen in the clinic. Related to these themes, the term triple curse from the title derived as one of the interviewees reported his feeling of being excluded due to his race, sexuality, and HIV serostatus. All of these stigmas led to Black gay men very vulnerable to HIV. Due to homophobia and HIV stigma, participants were rejected from those whom they usually leaned on support. Furthermore, the discrimination they faced not only caused psychological harm, but also physical violence, including being physically assaulted, pelted with stones, and forcibly shut out. Moreover, they often experience restricted freedom of movement, as one participant explained how he felt confined to his predominantly Black neighborhood after white men followed and verbally harassed him. As these stigmas are directly related to HIV transmission and sexual risk behaviors, it is important to understand the social and the structural problems that impact Black gay men. Thus, the policy should take into account of these factors and incorporate them into education, programs, and structural changes. Lastly, my discussion questions are: what are your thoughts on individuals having increased frequency of unsafe sex in order to feel a level of social acceptance? Can you think of other populations vulnerable to HIV and AIDS? What kind of stigmas do they face, and how would each stigma relate to each other? And these are the sources. Thank you.